And something that is often missed, I think, when we're talking about ketamine is, the route of administration and dosing. And as a physician, of course, that's something that I'm very tuned into, but
Mhm.
it really affects that suppression of the default mode. So when we do the oral ketamine, which is just 20% bioavailable, or we do IV ketamine, which is 99% bioavailable, and then there's dosing ranges in between that really affects that suppression at the default mode. So in, say, a psychotherapy, if you're wanting to do EMDR with ketamine, or IFS with ketamine, or somatic work with ketamine, you really want the person very much present and just a slight alteration of that non-ordinary state of consciousness, which would be very light dosing. On the other end of the spectrum, though, when we really squash that default mode, that's where you see that ego disintegration and the person really goes into a very deep, non-ordinary state, connects sort of metaphysically. You're not really doing therapy, but there are benefits to that. And I think as clinicians, something we really need to think about is what form of ketamine are we using, what dosing, and why? What is our why behind what
Mhm.
we're doing?